wise note, keep your face to the sun and you will never see the shadows. So a very warm, shiny, and healthy welcome to all of you. I sincerely present my heartfelt gratitude to all the members of society for the successful opening of Surgicon 2025. May Allah give us more success and peace of mind. Let me put a question to the hall. Did man get here by evolution or by creation? Questionable. It's a debatable topic in a modern science, which is continued to be explored every new day till today. The Quran uses the term taqdeer, which means programming, planning, which can be linked to the concepts of genetic programming in modern science. The Bukhari Hadith quoting says, everything in human body is destroyed except the cell, which they labeled as Ajab al-Zanab, and people will come out as per code in it. Allah said, does men think we shall not assemble his bones? Yes, verily, we can able to restore even the tips of their fingers. This suggests that our religion, Islam, and the Quran acknowledges the existence of planning or coding within the living human tissues in the form of DNA that dictates their development. DNA contains a built-in code, which is known as blueprint, a tape recording for normal people that keeps us all forms of life within their basic kinds. So, O humans, which kind of favors of your Lord would you deny? In the light of this, I would like to get the opportunity to invite our molecular genius of our country, Professor Mohammad Kamran Azeem. Professor Kamran is a PhD in biochemistry from Haji Ibrahim Jamal Research Institute of Chemistry. Currently, he's affiliated as a Dean Faculty of Life Sciences, Muhammad Ali Jinnah University. His research interests in human genome are the human genomics in medicine. Today, he will share his thoughts and research on the role of genomics in surgery. Sir, please be on the stage to share your thoughts on the subject. Dr. Kamran.
Bismillahirrahmanirrahim. Nahmaduhu wa nusalli ala rasulihil kareem. Thank you very much. I'm very thankful to the organizers and Dr. Munira for inviting me over here to discuss one of the very important development which is we are observing especially in all areas of biology, in particular in medicine. So today I will discuss the new development and new discovery which has been done since last, I think, 15 years, which we call as next generation DNA sequencing or new generation DNA sequencing, you can say, and try to explain one or two examples of its application which we have done in our lab since last several years in collaboration of our collaborators in different hospitals in Karachi. So excuse me if I explain a very basic thing which we normally study in molecular biology and molecular genetics, which explains as the so-called central dogma of molecular biology, which say that DNA code for the RNA synthesis and RNA code for DNA synthesis, and sorry, can I? So this is the basic concepts on which all of the biology or molecular biology is working, and another concept which is very important is the polymeric organization of all biomacromolecules like DNA and proteins and carbohydrates. They are composed of small molecules, and those small molecules, organic molecules, are joined together forming large linear biomolecules. Another concept is the sequence of their components. So the sequence is the major phenomena which is underlying all biological processes, and the sequence of nucleotides in DNA and RNA and sequence of amino acids in proteins are at the center stage of all biomolecular processes. And the answers of many questions we ask in biology is in the sequence. And another thing is the mutation, that is the DNA sequence changes due to many reasons. And this is important even during life processes and major cause of diversity on this planet, and it is the key reason of many diseases. So there are different types of mutation changes in the DNA sequence. The point mutation in which one base is changed, or duplicate sequences in which the DNA is duplicated or inverted, or one or more bases are either deleted or inserted. So there are different types of changes can occur in the DNA which can cause, some of them, very few of them can result in disease phenotype as far as human pathology is concerned. So, because of the importance of the sequence of nucleotide in DNA, it is very important to determine the sequence in the lab experimentally. So, the discovery was in 1977 when the first method, reproducible, that is doable method was introduced. And then, since then, we have been using that method. This method is called as Sanger method, which is still in use, but it is very difficult to do sequencing using Sanger method for large-scale human genome sequencing. So, so the breakthrough was in 2005 when the next generation sequencing method was introduced. Since then, now in 20 years, we the next generation sequencing has that is a tremendous application in medicine, in whole genome sequencing, in which all of the DNA of human which is present in human cell can be sequenced and then determine where is the problem, in which gene or in which DNA sequence the problem is occurring. And there are a lot of applications of NGS or next generation DNA sequencing in many areas, particularly identifying differences in genes which can be translated into the identification and diagnosis in many genetic disorders. So we have been using the so-called Sanger sequencing since 1977. It is very good. It is it has been a lot of applications, but it is expensive and time-consuming and cannot be used in large-scale DNA sequencing. So the so-called next-generation DNA sequencing is introduced. It is basically a paradigm shift in sequencing methods, and it is cost-effective, it is fast, ultra-throughput, and genetic engineering and cloning method, which was necessary in Sanger sequencing, is not is required in the so-called new generation or next generation DNA sequencing methods. So there are a lot of applications by which we can use by using NGS in whole genome sequence, in which all of the DNA in human nucleus can be sequenced, which is more than 6 billion base pairs, a huge amount of DNA which we have in our genome, in our nucleus, as well as the targeted sequencing also carried out, which is called as exome sequencing, in which only the protein coding genes, protein coding regions are sequenced. And if many people are mostly not interested in whole genome, but they are interested in particular genes, for example, in cancer and in many other disorders in which a pool of gene can be sequenced and analyzed. And there are many other applications in which we also can sequence RNA, which is the expression part of the genome, express part of the genome, and epigenomic and other applications can be carried out. So the NGS is driving discovery and enabling the future of personalized medicine, in which the personalized genomics is being carried out. So the NGS workflow as we do in our lab is we take clinical specimen and we carried out their DNA extraction from the tissues or blood or saliva or any other CSF fluid and so on, and then we carried out sequencing, and then a lot of bioinformatics and computing are carried out, and then we interpret the results on the basis of bioinformatics analysis, and then we write the reporting for clinician to work on. So this slide is telling us how the DNA is sequenced in and what are the procedures. I'm not going into the detail. And there are different types, as I mentioned, either targeted sequencing, in which a target means that specific regions, specific chromosomes, specific genes are sequenced, all whole genome sequencing, and exome sequencing, in which only the protein coding regions are sequenced. So we have been doing a lot of DNA sequencing. My group sequenced the whole genome for the first time more than 10 years back, and since then we are working on DNA whole genome sequencing and analysis. So having said that, because of the lack of time, I will try to explain one of our case study in which we carried out genome sequencing of a lung carcinoma patient, in which a 68 years old male diagnosed with the lung carcinoma, and the several tests was carried out. The first regimen was failed, and the second regimen was also started, and 6 cycles were, but there was no improvement. At that time, their relatives contacted us for a possible application of genome sequencing for diagnosis, and in order to hope of better diagnosis and treatment. We carried out the so-called exome sequencing of the patient. In cancer, it is not only the cancer tissue is taken for sequencing, also the normal tissue of the same patient is also carried out, and we call it tumor normal samples for sequencing. And then after that, a lot of computing and sequence analysis and bioinformatics studies, and we came up with 4 mutations in so-called driver genes in cancer, and then and those genes were in these 3 or 4 genes, and they were known to be involved in different carcinoma other than lung carcinoma. And so this is how we have been working on different application of NGS in cancer. So there is a evolving field in cancer management, in which people are working on it, to debating about mutation-guided therapy versus histopathology-guided therapy. There is another case study in which we carried out the genome exome sequencing of a hypomagnesemia patient, a genetic disorder patient, and on the basis of the exome sequencing, we found out the mutation was in a particular gene, and it was a novel mutation which was found in this patient. And so this is how the exome, we have been doing exome sequencing and variant analysis for better diagnosis and treatment of a number of different cases in collaboration with our collaborators. So the genetic studies of metabolic and genetic disorders have revolutionized the medicine, and their recent advances in high throughput DNA sequencing provide novel information which can be used for accurate diagnosis and possible treatment. And it is now possible and affordable to analyze complete genome in an individual or patient in few days, which was not that is possible again. And also the reduction in the cost of the sequencing has also creating a way to achieve complete genome level sequencing in less than $100 these days. And the personalized genomics is being used. And thank you very much for your kind attention. And
Thank you, Professor Kamran, for encoding the genomics to us, especially a genetically illiterate person like me. Hopefully, it would be incorporated in our oncoclinical practice, the NGS system, in the coming decade soon. Thank you so much. The difference between technology and slavery is that slaves are fully aware that they are not free. As a human, we started as a charge, but now we are the slaves to our own technology. Very true. As landscape of healthcare and medical treatment is undergoing transformative change globally, starting from AI and robotics, digital health, 3D bioprinting, personalized medicine, human fetal tissue transplantation, stem cell therapy, and regenerative medicine, and many, many more. It's crucial to find a balance between innovation and ethical practice, ensuring the new technologies and development are used in a responsible and ethical manner. With this crucial issue to be addressed, I would like to call up on stage our respected, esteemed educator, professional surgeon and renowned teacher, Professor Majeed Chaudhary, who is currently serving as Dean, Lahore Medical and Dental College, Chairman, Department of Surgery, Cancer Care Hospital. He is credited up to the date being author of 3 textbooks and several research articles, as well as being the chief editor to many journals. He has guided and has scored the forum of even the borderless doctors of SAARC countries on many platforms. Professor Chaudhary will address upon ethical issues in a wake of recent technological development. Sir, we would like to have you on the stage for this dogma to be resolved.
Thank you, Munira, for the introduction. Ladies and gentlemen, this is, I think, an issue which is cropping up. The new ethical dilemmas or issues in wake of recent technological developments. Technology is very rapidly transforming medicine, healthcare delivery, and research. From AI diagnostics and robotic surgery to genetic editing, as was mentioned by Professor Sab just now, and wearables, we are navigating a new frontier. While the benefits are immense and these advancements raise pressing ethical issues, the moral dilemma and legal gray zones and professional responsibilities we now face as healthcare providers are yet to be addressed. Ladies and gentlemen, developments will continue. And we have to learn to live with it. And we have to learn to live with these new changes and developments. Health ethics evolved into phases during the last few decades, and traditional ethics, which mainly prevailed until the 60s, involved essentially the relationship between the healthcare provider and the patient, and was dominated by the Hippocratic culture, which had provided it with a core of values for more than 2,000 years. What is ethics? It's essentially a formal study of what's right and what's wrong, and the study of basis of or principles for deciding right and wrong, and the analysis of process by which we decide what's right and what's wrong. Ladies and gentlemen, the ethics refer to custom among a group of people and to an individual person's disposition of or character, Ethics is grounded on socio-cultural, philosophical, or religious convictions of what's good and or evil. Ethics is considered as the effect of to find justifiable grounds for distinguishing what is right and what's wrong. According to World Medical Association, it's the study of morality, careful and systematic reflection, and analysis of moral decisions and behavior. As a scholarly discipline, medical ethics encompasses its practical application in clinical settings, and ethical codes in the different era were based on religious beliefs or the patient or needs of the humanity. Pardon me. Ethics also refers to the behaving properly and to pursuing right conduct, so that improper or wrong conduct is described as being unethical. Bioethics is something, which emerged after the Second World War, and people started using it after 1960s, and is popularly attributed to the Van Rensselaer Potter, an American medical researcher at the University of Wisconsin. He used to describe the range of ethical issues associated with developments in human biology. Essential pillars of medical ethics are anatomy, autonomy, beneficence, non-maleficence, and justice. I'll just take you through the history lines about the development of ethics. Rigid rules were laid as to the experimental treatment, and there was no accountability in failure to cure, as long as the standards of textbooks were followed. And severe penalties were, however, threatened for those who ignored the instructions. It started by Hammurabi in 1900 BC, and it's depicted in France in the museum even today. And I'm sure even our own medical ethics now that we take oath on is essentially based on Hippocratic Oath, which is 400 years BC. And then, it's amazing. This gentleman from Varanasi or Banaras, Sashruta, he developed this medical ethics, which was absolutely amazing. Please do find out on internet, what exactly the time doesn't permit me to go into details. But it was amazing how he would select people for training. And then, of course, Hippocratic Oath came later, which we all. And the Judaism, they also developed an oath in 3rd century. And Islamic medical ethics was described in 7th century, based on sources of Quran and Sunnah. Islam made it obligation upon the sick to seek treatment. And human life is sacred, and savior of one life is regarded as being the same as saving life of whole of humanity. For every treatment, for every disease, except old age, there is a remedy, as it says in Quran. Actions will be judged according to your intentions. Innamal a'malu binniyat. And ruling exists of euthanasia, contraception, organ transplantation, and abortion. And then, the Persians developed their medical oaths in 10th century, and so did Japan and China. in 6th century and 14th century. And then the actual written first ever medical ethics was in 1794 by Percival, and it's available. You know, Islamic oath was developed in a conference, international conference on Islamic medicine in Kuwait in 1981. Bioethics is a Native American product. Bioethics occurred as a reactive response to the biomedicine, technology advances, and cultural pluralism. International bioethics began more than a decade after the birth of bioethics in USA. In the 20th century, there have been numerous unethical and inhuman experiments performed on human beings. They were subjected to perform illegally, without knowledge, or without informed consent of the subjects. And these experiments were funded by United States of American government, CIA, military, and private agencies. You know, look, mustard gas, I'm sure you are all aware of these things. Mustard gas was tested on soldiers via involuntary gas chambers. CIA sprayed whooping cough virus on Tampa Bay. You know, the Navy sprayed bacterial pathogens, pneumonia, in San Francisco. And the Army released millions of mosquitoes in the hope that they could spread yellow fever and dengue fever upon Savannah. US infected Guatemalans with syphilis, I'm sure we have been studying in our pathology books, and did not give them penicillin, which was available in those days. And over 4,000 sacred and classified radiation experiments were carried out on people without informing them. You know, and surgical experiments were done like in 1840s. Marion Sims, who is often referred to as the father of gynecology, performed surgical experiments on enslaved African women, and one of whom was operated 30 times and died from infections. You know, an Irish woman in 1874 was operated several times. And psychological and torturing experiments, CIA conducted experiments on prisoners and mentally retarded, exposing them to pain, fear, and sexual abuse. And the modern international human rights movement, in a reaction particularly to mid-20th century ethical abuses by government using the power of law. You know, I have already spoken about this ethics in Islam. Now, ladies and gentlemen, at one end of the spectrum, human life are new reproductive technologies. At the other end, there are techniques that postpone death, recovery of sperm from the dead bodies of recently diseased men for artificial insemination, leading to birth of their posthumously conceived children. So there are a lot of things happening, and they will all need new technological and assisted reproduction, genetics, health informatics, and life extending and enhancing technologies, all of which require the participation of physicians, have great potential for benefiting patients, but also potential for harm depending on how they are put into practice. You know, in artificial inseminations, in one of the best centers of the world, I visited in November. And they were saying that now they are harvesting sperms from Central Asian states because people demand that their children should be fair. Organ recovery from bodies of recently deceased persons or for transplantation also enhances lives. And the scarcity of supply of transplantation of human organs and the growing demand for them from patients at risk. And, in third world countries, I'm sure you know and I know that people who influential people, they will jump the queue anytime, anywhere. The new challenges, ladies and gentlemen, they arise, however, at resuscitation of patients who have sometime been unconscious in a persistent vegetative state, which to no resumption of consciousness is possible. The dilemma is on the shoulders of the relatives would put it on the shoulders of the physician, and but they don't want to take the responsibilities for their own reasons. And the elderly patients who have recently been resuscitated several times. So all these issues we, as physicians, come across during your, organ replacement. For example, development of artificial organs, such as mechanical devices or porcine organs. There are specially bred porcines, where the organs are cultivated and transplanted to humans. I think it leaves a lot of ethical issues, particularly in the Muslim world. Xenotransplantation, like development of genetically modified or transgenic animals such as pigs, is very common in the West, whose organs can be removed and transplanted in human patients. Porcine skin graft is being used. It has been being used for a very long time, even when I was a postgraduate trainee in London. Xenotransplantation raises ethical concerns about the transgenic and other preparation of animals for recovery of their transplantable organs. Willing patients to receive it, and then there are organizations around the world for animal abuse. That also raises ethical issues. And public health risks from implanted animal organs into human populations. And of course, we in the Muslim world have a lot of religious constraints in this field. There are certain recent developments in the science and biotechnology, as Professor Sir was saying, and I think we are going to see a lot of genetics coming into it in years to come. And molecular biology introduced an additional ethical dimension, usually referred to as bioethics. A new ethical dilemma developed because of the growing gap between health needs and available health resources. The concept of health ethics was broadened to what are sometimes referred to as health policy ethics. Dilemma of many deaths in 3rd district is unacceptable. Animals and human beings drinking the same water leaves a lot of ethical issues for the governments. Ethics move from being a personal matter limited to the satisfaction or dissatisfaction of an individual to a social matter dealing with mental and social well-being of the people at large. The WHO constitution also gives a lot of importance, particularly after the Second World War. You know, it is concerned with justice, rights, respect of human beings, dignity, autonomy of the individual, and respect of the community. You know, respect and equal treatment. I think, I think there are a lot of disparities which exist in certain part of southern Punjab and Sindh. You know, if I'm a very powerful minister, I'll get all the funds for my people with utter disregard of the other areas which need development and need money. There are a lot of current issues, ladies and gentlemen. I'm coming to the end of, sorry if I've taken a minute longer, like surrogacy and refusal to immunization, you know, human cloning, and don't attempt resuscitation, physician-assisted deaths in US and European countries, and gene editing technologies, and gender choice in IVF, sperm banks, superhuman disease eradication through genetic mutation, euthanasia, and physical assisted suicide. So I think we'll continue with these issues. Medical technology will continue to evolve. Our ethical frameworks must evolve with it. We must advocate for transparent, equitable, and patient-centered innovation. Interdisciplinary collaboration is the key, and continuous education on tech ethics should be part of our professional development. You know, non-maleficence, autonomy, justice remain important pillars of bioethics, and physician-patient relationship remains the cornerstone of medical ethics. Modern developments have inherent new ethical issues, and modern ethical issues would continue to be influenced by religion, culture, and advent of techniques and many more. Yesterday there was talk about the robotics in surgery, and robotics without involvement of the human beings. You know, who will take the responsibility? I will leave all these things to your imagination and thinking. Thank you very much, ladies and gentlemen.
Thank you, sir, for discussing the dilemma of an unforeseen monster and controlling him with the ethical fence. Every accident is a notice that something is going wrong with a man, methods, or material. Investigate, then act. Is quality safety? Is safety quality? I think clarity is priority. Ladies and gentlemen, let me have the honor to invite upon stage Professor Asim Jaffery to answer this ambiguous question. Professor Jaffery is FRCS, Masters in Hepatobiliary Surgery, Fellowship in Liver Transplantation, Diploma in Medical Education, and Executive MBA in Healthcare Management. Currently, he's working as a consultant surgeon at Agha University Hospital. Professor Jaffery, please clarify our vision on this puzzle theme.
Thank you very much. Thank you for kind introduction.
Yes, this one.
This is the one.
No, forward and backward.
This is forward.
This is forward. This is backward.
Thank you. So quality and the safety is the core issue. If it is not, it has to be. Today I will be sharing the experience of our hospitals, off-campus hospitals, how they managed, what they faced in compromising the quality and safety, and what resources they used to fix these problems. The initiative was taken by Dr. Asim Bilgwami, and he was our former chief medical officer. Now the ownership lies in the staff of these hospitals. So just a quick disclosure, I don't have any personal, financial, or other conflict of interest and associated to it this initiative. So this is the famous saying by Dr. Donald Berwick: our healthcare systems are built not just on science, but on lessons we learned, too often and hard way. This is the basis of a lot of reforms took place in UK, and this incident is known as Bristol Heart Scandal. And in the periodic surgery unit, it was noted that the mortality rate on that unit is double than that of the average in UK. So the findings were 170 deaths out of after 1,800 patients. And out of that, up to 30 to 35 were avoidable. And the findings said the surgeons exceeded their competence, there was poor clinical governance, and failure to act on concern. There were whistleblowing, but they were ignored. And the impact was staff were held accountable. Some of the consultants lost their GMC registration. Reforms in NHS patient safety governance and introduction of appraisal and the revalidation system. The initiative which took place were the clinical governance framework, and this is the framework to focus on the quality improvement and accountability. Then when we talk of the quality, we have to set the standards. The standards were the NICE guidelines based on clinical evidence. There was Commission for Health Improvement, which used to monitor and improve NHS clinical quality. Doctors' appraisal, this was yearly appraisal, and after 5 years, there is revalidation of their registration. This was to ensure the performance and professional development. There was public outcome reporting. Transparency in the surgical results has to be transparent and open to the public. Duty of candor, the honesty with patient's harm. We have to talk to the patient, tell them what harm has been done with our interventions. Now coming to the clinical governance. So it's actually a framework that ensures healthcare organizations are accountable. They are not above the law, and accountable for quality, safety, and satisfaction of patients. It involves setting standards, monitoring performance, taking action to improve care. It's a system for continually improving the quality of services and safeguard high standards of patient care. The change of culture requires motivated clinical champions and leaders. This is a basic principle of the change management. There has to be a leader which is the role model and which takes the lead in bringing the change in the culture. Without change in the culture, I don't think so anything can be changed. So the clinical governance thrives in a culture. The leader and the system has to develop an environment where these following things should take place. Number one, the quality is a core business priority. This has to be part of the culture. Teamwork drives continuous improvement. Openness to acknowledging and addressing problems. Commitment to personal development and long life learning. Staff feel valued and supported in their roles. Patient experience is central to care delivery. continuous care improvement in routine practice. Healthcare standards are proactively implemented. Now, implementation of the clinical governance framework in 4 off-campus hospitals. So, Khan University has got 4 outreach hospitals, and their scope is limited to gynae ops and pediatrics. Out of these 4, 3 are in Karachi, 1 in Hyderabad, and they are more focused on secondary care hospitals. There were certain problems related to the safety and quality. So drilling down those events, we came to know the problem lies in the leadership, the communication, decision-making, and teamwork. So we learned from the experience of UK, we introduced Clinical Governance Committee. And this committee is led by the Chief of Medical Services, which is a senior clinician who has got the leadership skills. And this committee is sort of a tripod stand in which the 3 limbs, the first limb is the Chief of Medical Services, the next is the hospital administrator, and the head nurse. These are the core members of Clinical Governance Committee. There is a paradigm shift of the command and control. In the previous system, it was the hospital administrator who was running the clinical governance. Now it has moved to a senior clinician who has got leadership quality. Now the 7 pillars of the clinical governance, which UK as well as we have focused. That is clinical audit, evidence-based practice, clinical risk management, education and training, public involvement, information management system, staff is probably the typo, and leadership engagement. This is the RACI matrix for management. The person should know who is responsible and what is the duty. So in the bottom is the clinical staff. They are the responsible of the task. Above that, there are 4 clinical governance committees. They are held accountable. If anything goes wrong, they have to run the system. These committees are reported to the Clinical Governance Council, and they are the one who are the advisory body, and the clinical governance consults them. Then we have to inform the higher authorities, that is the Joint Commission of Pakistan, Joint Staff Commission, and Board of Trustees. So the key responsibilities of that committee and the Chief of Medical Staff lies in lead clinical service, that is develop, improve and ensure high standards of care delivery. Identify and implement growth opportunities. Ensure quality of care and provides quality of care and providers. Strategic advisory role. Promote quality and safety culture. Regulatory compliance, risk management, support education and academia. Now, how far we have reached? Is it successful? It is too early to say. But the system is in place. We have got outcome indicators which will let us know how far we are going, and particularly as compared to our previous administrative performance. So some of the clinical indicators which will reflect our outcome, and we quarterly visit these outcomes and then compare it to where do we stand. Say for example, the quality related indicators are sensitive complaints, it has to be less than 3%. Medication near miss errors, it has to be 0%. Patient satisfaction, more than 92%. Related to the pediatric, these are some of the indicators that we have got a huge list of them. Rate of blood culture contamination has to be less than 3%. Use of antibiotics in acute watery diarrhea, 0%. Anesthesia-related outcome indicators, preoperative anesthesia assessment has to be 100%. Similarly, pre-induction reassessment has to be 100%. Conversion to regional to GA during C-section should be less than 15%. Now, OBGYN outcome indicators, booked pregnancies resulting in stillbirth, 1.5% to 2.5% has to be less than that. Unplanned return to OR, 0.03% or less. Rate of emergency cesarean section, less than 25%. So the conclusion is we don't just learn from books. We often learn from things going wrong, if we learn. So thank you. So I'll answer your questions later on. Thank you.
Thank you, sir, for giving us a comprehensive approach towards balancing safety and quality in healthcare. The evolving trend of seeking treatment in other countries all the way through travel is the indicator of globalization of the healthcare system. The migration pattern of a healthcare services for specialized treatment with lower cost is the armamentarium of modern medicine. To articulate the thoughts of this topic, which promotion of medical tourism in Pakistan, I would like to welcome Dr. Mubashir Iftikhar, Director, Medical Tourism, Medask Company, owned by Fauji Foundation. Dr. Iftikhar is a graduate of PMC Faisalabad in 1996. His journey reflects a commitment to ushering in transformative change in healthcare, affirming a pivotal role of IT in shaping the future of patient care. Worked as a medical officer in National University Hospital, Malaysia from 2000 to 2007. He has been working as a medical tourism advisory person and setting up the Malaysia Healthcare Travel Council system and the council body. He had extensively written on medical tourism and running one of the leading linked group named as Medical Tourism Facilitators for 15 years. Sir, please be on a stage to guide us on this novice topic of medical tourism in Pakistan.
Thank you so much. Assalamu alaikum wa rahmatullahi wa barakatuh. And very good morning. Thank you so much, Dr. Munira, and organizers for inviting me on this very important topic, promotion of medical tourism in Pakistan, challenges and solutions. This is the clicker. So what is medical tourism? Basically, it is patients who travel cross-border to another country, and it has like inbound and outbound medical tourism. Inbound is where we say patients who are coming towards us, and outbound who are going away. Means if I'm in Pakistan, if patient coming to Pakistan, we call it inbound medical tourism. And patients who are going outside Pakistan, we call it outbound medical tourism. And intrabound is within the country. If I may ask, how many of you have heard about medical tourism? And if you can raise your hand, please. Thank you. So not many, basically. And it's an evolving trend worldwide. So let me go back. Can इसको ज़रा ठीक है हाँ क्या ये नीचे वाला आगे जा रहा है कौन सा ये पीछे अच्छा अच्छा ओके Yeah, so basically, this is the market trend. If you may see that by 2024, the market is about 47 billion US dollars. The compound annual growth rate is about 18.8%. That means the growth is tremendous, immensely fast-paced. And you may have heard India or maybe Turkey for the sake of like people going for hair transplant. Medical tourism, I mean, here some of the countries I have put in, like if you see India, Thailand, in 2024, they made about 11.38 billion US dollars out of medical. Only one hospital called Bumrungrad Specialist Hospital in Bangkok, Thailand, alone makes $1 billion US a year. And it's not like in last few years, it's more than a decade they are making $1 billion US. There are 40 translators present at one time on the floors of the hospital. Different language translators, humans, 40 humans working to translate people. They're about, at one time they claim that they have patients from more than 60 countries in their hospital. It's a huge hospital. And they call it, that is from where the medical tourism started. Similarly, if you see India, about 10 plus billion US dollars, Turkey about 3.43, and Malaysia about 1.5 billion, where I worked as like medical tourism facilitator initially, then as medical tourism provider in hospital. The growth, if we see, if the growth of this trajectory, say, if it grows with the 12% for Pakistan, which is about $500 million, and this is like more of a hyped up figure, I assume, through some rough calculation, we be about 2 billion by 2029, which is not much for a size of a country with the bordering countries or geolocation which we can think. What we need to do is to take upon this industry, understand, learn, and develop it to improve the overall conditions of our own hospitals. Factors influencing the choice of medical tourism. The cost of treatment, basically it is the most important factor, the affordability aspect of it in medical tourism. Quality of care, waiting time, specialized expertise and technologies, all these are drivers of medical tourism. Certainly medical tourism, along with the accessibility and the accreditation, is very important. If you think of countries from where medical tourists travel abroad, say UK or US, they will ask this: the hospital which I'm going to, is it accredited? Means it has something like JCI or some other accreditation system. So these are very, very important. The key drivers are high quality treatment at low cost, right? Expanding private healthcare infrastructure. So means we are growing with modern and well-equipped hospitals. Increasing demand for affordable costs of procedures means like we can do all modern technological procedures at low cost. And the challenges are regulatory issues. Certainly if we have some regulation against this, like in Malaysia, when we started developing the Medical Tourism Council, which was way back in 2009, I was the only private person with the ministries of the Malaysian sitting under the Prime Minister's directive to set up Malaysia Health Travel Council. We were posed with the question that we cannot give ICU beds to international patients who come to Malaysia for seeking treatment with the cost, means making payment for it. We cannot give them ICU because these are subsidized by the government, even in private hospitals. So these are very important aspects when we think of medical tourism, developing it, that we keep in view the regulatory issues. What is most important? Marketing, promotion, quality assurance, and accreditation. So developing proper comprehensive marketing strategies. And these strategies, coupled with the collaboration with local and international agencies, to ensure that we have a very well-developed and a well-directed marketing. So we cannot just hodge the marketing campaigns. Participating in international medical tourism conferences is very important to know how we benchmark our services against others. Say, when we will start, as all of you have not suggested that you know of this, but when you will probably, inshallah, will start this journey of providing treatment to overseas patients, then you will see how important it is to benchmark yourself against your competitor. Who is our competitor? Probably India. So we have to participate to understand how do they sell. What do they suggest or try to convince patient with? Implement international accreditation, as I suggested earlier, JCI, and provide incentive for hospitals. It is like when we developed MHTC, Malaysia Health Travel Council, way back in 2010 when it was inaugurated by the Prime Minister of Malaysia, we gave 200% tax deduction to hospitals who were given the emblem or the logo of the Malaysia Health Travel Council. Means we registered those 26 hospitals by then, and we gave them the logo registration that they can provide medical tourism facilities, and they can claim 200% tax deduction based on that. So that is very important to provide incentives to our hospitals to establish these services in a better way. May I have some water, please? Thank you. So Pakistan's potential in medical tourism, low cost, high quality. That's absolutely amazing. What Pakistan, like today, a CABG in Pakistan costs, say, about 4,000 US dollars in many of the established good institutions. While the similar CABG in US costs, say, 50 to 70,000 in average, 100,000 in a good institution. Similarly, if you go to India, that may cost about 10 to 15,000 US dollars. If you go to Turkey, it costs about 20 to 25,000 US. If you go to Malaysia, price even increases. So that's important. Skilled surgeons. Pakistani doctors, I can bet with you, they are the world-class, best in the world. Not less than that. Thank you. World-class hospitals, we have to set up improved hospitals around the country because we have to understand that hospitals should be well spread. Tourists they don't land in one specific destination. Say Ethiopia, we have 2 flights every week coming to Karachi. So if we target Ethiopia as a country to send us medical tourism patients, we have to set up, ensure that we have proper hospitals who are catering this, providing incentives, and running some marketing campaigns. They have translators of Ethiopian languages in Karachi. Because we can't expect them to come to Karachi, then take another flight, go to somewhere else in the country to get treated. So these important understandings must be there. English, we are almost everybody can speak English in Pakistan. Even now, a rickshaw person can speak quite comprehensible, good English. The most amazing thing when I was given this task to establish medical tourism in Pakistan is that we have amazing 1.1 million overseas Pakistanis living in USA, in UK, in Europe, in Middle East, in Saudi Arabia. Amazing. So if you just target them, build some databases, run campaigns, educate them. How important is the PET scan in Dubai costs about 4,50,000. While if they come to Karachi, maybe JPMC can offer them for free. But if not free, 150,000 is the cost in Pakistan. So how can they take a flight, 100,000, maybe 80, 70,000, get the PET scan done, go back to their country. And how do they know? They don't know. Who will tell them? You have to educate them. Diaspora and then our geolocation of Pakistan, you see Pakistan is basically a hub destination. When you think of PIA, whole world used to land in Karachi, and from here, the traffic used to go to destinations. Pakistan is the geolocation-wise is one of the best placed country in the world, if I say so. Sorry. So, building healthcare branding through medical tourism, clinical excellence through quality, very important as I shared. Staff training for soft skills is very, very important. We must know that we don't smile when somebody comes to us. We just like, okay, you are registering and let me register you quickly and send you to where you need to go. But we have to learn from how Thais do it, how Japanese do it, how other nations do it well. This is very important that we should adopt this in our hospitals. We must have some accreditation, and for that I think Pakistan should develop its own established accreditation system, which runs run across the country, means in 4 provinces. Healthcare has become a provincial subject. For that matter, I think provinces may not understand that, but that has to be a centrally run, well-established, well-equipped accreditation body in Pakistan. Doctors must publish their stories so that we can tell patients how good we are in providing these services. Publish in patient reviews in international and local journals and articles in publications featuring hospitals and diaspora communities, same that thing, and collaborating with travel health bloggers around the country. These are the impacts, immense impacts basically. Why every other country? Saudi Arabia does not need dollars, but just few days ago, Saudi Arabia published a paper. By 2030, they want to be like 50 billion US dollar earned in medical tourism alone. Why Saudi Arabia needs it? We have to ponder, we have to think. So it's very important. This is my thinking, what should be a roadmap for strategic roadmap, because I think many of you are decision makers in your hospitals. So launch pilot medical tourism program in 3 to 4 flagship hospitals. Means if you all can gather, think that this is our industry, we should build 3-4 hospitals should take up. They should build what is importantly required and start. Multilingual website is very important, and digital outreach like CRMs, customer relation management systems to attract diaspora and other patients in an organized way. Train international patient coordinates in select hospitals. Then in midterm, establish Pakistan Medical Tourism Authority, PMTA. That is very important. Understanding, creating industry out of it, we need to have a body, some commission or some authority to do this. For that, I've written here PMTA. 5 centers of excellence. We cannot just do that. We can do everything under the earth, under the sun. We have to be very specific that we are best in, say, orthopedic surgery, cardiology, oncology, something we have to understand. Start with, we cannot sell each and everything. Even if for hospitals, I think if they take up on medical tourism, they should see where they are best in, and they should promote that particular aspect. Fast track medical visa is very important. Recently, Pakistan has announced 126 countries they can have electronic visa for free, probably, or maybe at $10. Pakistan becomes a trusted regional hub after some, and it requires some time. Like I remember in Malaysia when Prime Minister launched in 2010 medical tourism as an industry under the Malaysia Health Travel Council, MHTC. It took us 3 years in Malaysia to say that, okay, now all the tourists who are coming to Malaysia will be charged double. Before that, the charges were all same like their usual public patients who were paying to private or government hospitals. But after that, it became double. So we say it like when you establish yourself, you certainly will say, no, you are different from us. Recognition global medical. If you search medical tourism on website, you will see Pakistan is not visible at all. Hospitals should say that this is a key important health tourism, medical tourism, health travel, global travel investments. There's so many keywords. Hospitals and agencies and people who work in this should develop that. And integration insurance, international insurance, a lot of insurance providers, especially from Europe, US, they would send their patients to Pakistan on behest, like they can get their reimbursement. So if reimbursements are not available based on quality standards, accreditation, probably patients cannot come. So we have to develop accreditation and then talk to these insurance providers to establish that. Sorry for very thin font here because of too many things. Increased funding via foreign patient inflow. Increased funding, sorry. So this is like when you have increased flow, the fund should be, as I earlier suggested, that double tax deduction, things like that. Hospital giving incentives, giving more proportion of money to doctors who are providing this. Better use of hospital capacity, certainly we can consume improved capacities when we have foreign patients coming, because healthcare is a funnel. We know which community are we trying to sell. So that will improve. Incentivize retention of talented specialists and nurses. Local patient service improved due to higher standards. Impact of specialist doctors, I added this morning, that I said that boost in income, procedure volume and reputation of the providers, surgeons, doctors. And opportunities for clinical research, innovation, better job satisfaction, global collaboration. So these doctors who are providing these two, and then we have seen the trend that when the doctors who start providing these services, they become celebrities. So like in 2-3 years, their name shines like they are the best in the world. For the provider community, say if we have a traffic coming from Afghanistan, coming from Ethiopia because they have a flight here, these doctors can be seen that they are the best in class in Ethiopia. You will be surprised they are published in their newspapers, in their magazines, the best providers, things like that. So what are my recommendations? Create a unified medical tourism strategy. So we have to, private hospitals and government hospitals and all of us, we have to unite to think what is our strategy? In which part, who should take upon what? Like say in Karachi says they are best in cardiology, in orthopedic, in oncology. So that should be here. Somewhere else, maybe cosmetics and aesthetics, and somewhere in dentistry, things like that. We have to establish as an industry. Invest in brand Pakistan, a healing destination. So we say we have to promote not your hospital alone, that my ABC hospital is best in class, but also talk of Pakistan as the best destination, because medical tourism is not just medical. We say you come here, you heal and go to visit nature in Pakistan. By the Arabian Sea, if you can lay and have that wind blowing beside your bed and you be cooled with that, I think that's a great healing experience if you think of. Build trust with the diaspora. As I said, Pakistanis, overseas Pakistanis, if you can ensure that they will come to you rather than go to their local provider, they can travel, have some fun, enjoyment trip in Pakistan and get treated as well, is the best way. Focus on high impact specialties, orthopedic, cardio, oncology and all those, and integrate all service hospitals, labs as a unified service provider rather than just here and there. Thank you so much.
Thank you, sir, for briefing us this neophytic terminology of medical tourism in our medical fraternity. So, any questions from the hall? Yes. Mic, please, to her. Mic.
Assalamu alaikum. I'm Professor Shafiq Rahman. what a good concept. I think our neighbors have taken this concept long time ago, and they have expanded a lot in medical tourism, and they have first just because of medical tourism, and they have developed a center of excellence just because they have been attracting foreign patients. I think in our circumstances, there are certain organizations like Pakistan Medical Association, PIMA, and private hospital associations. They should all join hands with the government to develop this kind of a facility. And it's a very good idea. Need to develop it for the future. Thank you very much.
If I may just add here, like, as very rightly said by the Professor Saab, that see, I'm working with the so-called the decision makers in Pakistan. So if you can, like, maybe reach out to me, I will put this to them, that how we need to establish a collaborative effort that we all can work under one roof to build this very important industry. Thank you.
Okay, Assalamu alaikum. I'm Maria Tariq. I'm a radiation oncologist at Aga Khan University. Okay, sir, thank you for this very important concept. I have one question, that how do you think this medical tourism can help improve the quality of cancer care in Pakistan, especially for our populations who have limited access to cancer care?
So it's a good question. Basically, see, medical tourism is creating awareness. Many, they may not know. When we are treating cancer, we create awareness. So not just the international patients, the local patients will also get benefited. With that, when we have better funds coming from abroad in dollar value, we can use that to provide better services. When you have, say, LINAC at your hospital, then you can basically provide better services. It may not be just used for that international patient, though it is required by that. Because they may not come for, say, run-of-the-mill services or treatment options which are already present in their country. They travel 1,000 miles and come here for that. Certainly not. They will come for some high-end specialized procedure. When they will come, what will be the outcome? The locals will benefit as well. So that's important to understand. Thank you.
Thank you. I just wanted to add to what you have said, that if we see the Indian model, I had some friends over there, Reddy and others, and they were developing their centers, and they have grown astronomically just because of the marketing and producing some excellence over there. So once you start this, excellence come per se on itself, because you are getting patients, and then you'll have to improve yourself. You're selling your brand. So that is a kind of a thing.
I've seen Indian hospitals, like when I started in 2007 medical tourism, I used to meet them at international forums. They were just like ordinary hospitals. But after 5, 7, 10 years, they become centers of excellence. They have amazing wards, just like 5-star hotels. They have super specialty doctors traveling from US, UK to provide services, treatments on like locum basis. This is something, bro.
Can I answer on that, Giro? So taking Dr. Fatma's question forward, so the answer is, if we are developing these facilities for international patients, our local facilities are already going to, develop better. So indirectly, our local population is already going to get, benefits of this betterment. So we have already applied this system in Evercare Hospital, Lahore. So we're attracting a lot of patients who travel on their own. Of course, there is no government agency available. However, we are trying to attract more and more international patients because they can get excellent healthcare at very affordable costs. So the thing is, once you improve for international patients, the local patients are already going to get benefit out of this. So, of course, the lead has been taken by the private organizations. The government has to think that they can already earn a lot of money out of it if they implement this thing in the government practice as well.
Can I make a comment here? Having been the president of the SARC Surgical Care Society, had a lot of chance to visit India. And would you believe a very small city called Jalandhar, they have the largest number of hospitals in the world vis-a-vis population. And the majority of them, they attract, these foreign nationals or Indians coming for medical treatment. Would you believe that in this city, there is no medical college, but they have hospitals? For example, they have, in just subject of eye, for example, they have anterior chamber hospital, they have posterior chamber hospital, they have retina hospital. So they have developed so much in India. They are not attracting people for nothing, but you have to work very hard on it. And, I think a lot of facilitation needs to be done by the, and of course, the, security issues in our country, which have been unduly highlighted. Partly right, though. But I think we have to work on those frontiers as well before we go on to this medical tourism.
Thank you so much. Any question?
Sir, I have a question. Sir, your presentation was very nice regarding the inbound tourism. What about the intrabound? Because there are various patients coming from the interior and they are just going to the JPMC or civil, but they don't know whether their respective department is functional there or not. So what you guys are doing for that awareness?
Good question. I agree that, but there should be a proper effort, well directed, that this particular facility, say, NICVD used to treat patients from all across Pakistan when it was AFIC in Rawalpindi, where I basically helped establish medical tourism. They've been the center of excellence for cardiology, and they are still one of the best in the country. An issue is creating awareness, suggesting to people, how do you travel, what facilities you have, where you can stay, how will you get, maybe if there is a Pashto speaking person, do you have a translator in that hospital if they go for liver treatment to Gambut, whether they can get treated or not there, be it maybe some other Gilgit, Balti or something, like a language which we think of having difficulty in getting to translate to. So things like that. We have to create proper awareness campaigns to do that. And it is not the government's, basically private sector has to take initiative and create awareness. And maybe you can say that for the local sake, we charge them 500 rupees. For you, we charge you 700 rupees as well. It's quite justifiable. At this moment, my focus is international medical tourism, not intrabound. So that's the issue.
Good question, Dr. Zareen. I think this question can be answered by our political or the government body, who can be the better charged to answer this question. So my question to Dr. Kamran is that, sir, the NGS, the next generation sequencing, is this test would be the future of every oncology patient as a routine, or it has to be offered to the special group of a patient, just for the understanding of the house?
First of all, this type of test is available, is now available even in Karachi and in many other cities, even in Lahore, in Islamabad. So it's available. The question whether it would be necessary for each and every patient, it's upon the oncologist, I would say.
Okay.
Because if an oncologist would think whether this test is necessary for the diagnosis and for clear understanding of the disease, I think it's upon the oncologist. Okay.
Yes, sir. Professor Shafiq? Mic, please.
In Karachi, we have a very good center at Karachi University. They are doing genetic sequencing.
Yes.
Research, and it opens up a big avenue. Dow University of Health Sciences has also acquired genomics now, and I think they'll be starting soon. So more facilities are becoming available. Yes, there's a price tag to it, but we have to understand that there is a future, especially familial breast history. So you do tagging on them, and so you can give the outcome. Sometimes a very young patient comes to you with no disease and says she wants bilateral mastectomy because the whole family had a cancer. So this is a patient where you can especially choose and send it for genetic coding, sequencing, and then we can give some answers to them. And so there's a lot of scope. It's not being utilized as it should be, but there are two centers which are coming out. Karachi University has got an excellent center. I've seen that they're doing PhDs over there, so people are coming out with genomics, and Dow University has just opened a center becoming in a quite big way. I hope so.
Thank you so
Can
much.
can I make a comment?
Yes, sir, please.
Ladies and gentlemen, we are talking of very hi-fi genomics, AI and robotics and everything. I'm looking after now, at this stage of my life, Cancer Care Hospital, Lahore, where we provide free treatment to everybody. Would you believe, last week I operated upon a lady who had a cancer of breast, which we weighed after the surgery. It was 8 kilo. We have not given education to people. We have not been able to provide them with wisdom. We have not been able to provide them with health care. I don't know, to me, pardon me saying that, we seems to be a directionless nation. And I'm sure same would be the case in the rural areas of Asim. Alternate medicine has played havoc with human health in this part of the world. Thank you.
Very true.
Professor Majeed, I do agree with you, and that's why we want to focus on intra-bound tourism, and we should pay attention to spread the awareness. That is very, very, very important thing. Well before inbound even.
I think medical tourism is there. It's not organized, it's not
Yes.
sponsored by the government, but I tell you,
Yes.
in Karachi, Lahore, Islamabad, Peshawar, you get patients from many countries, for this treatment. For example, talking about this cancer care hospital in Lahore, we get a lot of people, mostly Pakistanis or from Afghanistan, who come for medical treatment.
Yes.
And they don't mind paying whatever.
That's what I was saying. Okay? We have a lot of patients coming from interior, but they don't have directions because they don't have awareness. So we have to focus on that. Thank you very much.
Thank you. Professor Nadeem?
Nadeem Abbasi, Radiation Oncology. Dr. Asim, mashallah, you have a lot of experience. So it's more to gain guidance from you than anything else. UK, you remember that in UK tumor boards were not mandatory until 1st of January 1997. I was there actually that time. So I witnessed the flux, the whole change, that it became mandatory after a lot of efforts. The same which is your expertise. Now in Pakistan, majority of the cancer patients are treated without operation in the tumor board. Overwhelming majority, I would say 80%. And my team is working on this since the last 19 across the country. And still, we don't have a single mandatory tumor board in the country. All are voluntary. We do it Sunday morning, city tumor boards. So with your expertise, a person like you with us actually, how can you explain, first of all, and justify that we are practicing without tumor boards and we are treating patients without this? Professor Majeed Saab, mashallah, he also mentioned that interdisciplinary is important.
I think that
So
probably...
it's a country issue. It's like not
I
a
think
hospital
it's not
issue.
entirely true. For example, I can talk of city of Lahore. We don't take any patient to theatre unless it goes to MDT, and that's held twice weekly. And same is true in Shaukat Khanum Hospital. A lot of my students are, bigwigs there. And in these two cancer hospitals in city of Lahore, I'm not sure about others in rest of the country, but in every patient virtually where a decision has to be taken, Like the MDT in my hospital, about 15 people from all specialities, and we take a joint decision and act upon it.
Sir, I know about this, and also in more Lahore. It's not a matter of a hospital. In my hospital, university, we are to 90%. So why I'm talking about the country, the whole country cancer patients are our patients, not my own hospital patients. So that is why I requested Dr. Asim that how can you make, for example, make sure as a national citizen of Pakistan, by so much of your expertise, and then you are seeing actually patients.
What my
like
take
this.
is that
Thank you.
if you want things mandatory, then it has to be legislation, it has to be through the government. So people are doing it. Even in Karachi, there are private forums. They are running MDTs regularly. And then the hospital also doing, as Sir said. But again, we are not the lawmakers. What we can do, we can take care of ourselves. We can pressurize the government. We have got connections with those who have got connections with the government higher authorities, so they can take the lead. And probably the lead has to be taken from the government institutions, because they are serving about 40% of the healthcare. If you look at the history, when the Pakistan was created, it was 10% private and 90% was the public. By 1970, it was 30% public and 70% was government hospitals. And now currently it is, what I'll say, it is really a disappointing. Up to the 75% healthcare is provided by the private institutions. So government is gradually shrinking instead of expanding. So what my take and what my advice, what we should do, within our limitation, wherever we are working, MDT has to be mandatory. A small hospital, a big hospital. If you don't have oncologists and radiologists within your institution, get help of certain forums, even in Karachi and other institutions, you can get their help. In my private practice, if I need an advice for MDT, I contact my friend who are running these MDTs in private setup. So that's my take. Without government and public partnership, we can't progress in this.
Can I make one comment? Having spent about 50 years in the health profession, unless you make medical personnel in charge of the things will never improve. Bureaucracy knows nothing. Anybody who is working in finance today is made a Secretary of Health tomorrow. What the hell would he know? So I think until you make, medical professionals in charge of the things, nothing will improve, unfortunately.
Thank you very much, ladies and gentlemen.
Just last comment.
Yes,
And
please.
my presentation was just a paradigm shift. So we have made a senior leader, clinical leader, as the person who is running the hospital. Before that, it was the hospital administrator who had the experience of running the hospital, MBA in the healthcare profession, but he and she is not a doctor, not a senior nurse. So that was lacking. So now we have made a clinical governance committee, which is headed by a senior clinician and supported by the administrator and other services.
Okay. Thank you, gentlemen, for your detailed answers. So now I would like to request Chair Scientific Session, Surgicon 2025, Professor Masood Mirza, to present token of gratitude to our eminent speakers for Plenary Day 2. Professor Masood Mirza. Okay. Now I would like to invite Professor Kamran Azeem to receive token of appreciation. Ladies and gentlemen, please give him a big round of applause. Thank you so much, sir, for coming. It's a much needed topic to be discussed, genetics in Pakistan. Let me have the honor to call upon Professor Majeed Chaudhary. Give him a big round of applause. I want a thunderous, prolonged Applause for him. So we are really honored that you are being the part of Surgicon 2025 in Karachi this year. Thank you so much. Now I would like to invite Professor Asim Jaffery. Sir, your talk was mind-provoking for us. Thank you so much for enlightening us with the new thought process. Last but not the least, Dr. Mubashir Iftikhar. Sir, thank you so much for creating the detailed discussion about this novice topic, medical tourism in Pakistan. Give him a big round of applause, ladies and gentlemen. He has come all the way from Pindi to attend this conference. To conclude the plenary session with a happy note, keep smiling and shining, and have a tea. Tea has to be served outside. Thank you so much.
We will now take a short 15-minute tea break. Please proceed to the conference hall. The session will resume after 15 minutes.